I'm David Rosensweet, MD. I'm a medical doctor and a graduate of the University of Michigan Medical School. I began treating women in menopause with bioidentical hormones 25 years ago. In 2001, I wrote my first book on this subject, and its sixth major iteration was published in 2017. I organized a national summit meeting of leading physicians, laboratory experts, and compounding pharmacists in the bioidentical field in 2004. I spent 85% of my professional time training and mentoring physicians and nurse practitioners to become expert at this work. The remainder of my professional time is devoted to consultations with patients in menopause. I'm furnishing each of you with a printed copy of my opening remarks with citations, as well as a thumb drive that contains the full articles and other references that I refer to, and includes practical tools to assess, instruct, and monitor patients, testimonials from my patients, my CV, and a PDF copy of my book. I'd like to address 5 key principles of bioidentical treatment. The first is that topically applied estrogens and testosterone meet the highest bar of safety, whereas oral formulations do not and carry significant risk, including thromboembolism, increased breast density, and more. The second is that the safest and most efficacious estrogen formulation is the combination of estriol plus estradiol. Topical estriol confers special protections and risk reductions. Much, but not all of this, relates to the discovery of estrogen receptor site beta. Topical estriol is available only from compounding pharmacies. The third principle is that individualization of hormone prescriptions for each patient is a critical part of optimal treatment regimen. The variability of woman to woman in absorption through the skin and mucous membranes, in milligram per milliliter needs, in the ratios of E3 to E2 because of hormone metabolism, and in the variable sensitivity to administered hormones all lead to an almost infinite variety of combinations that emerge as clinically relevant. Thus, each and every patient requires a custom prescription, and these are only available from compounding pharmacists. It is unfeasible for the multitude of these possible combinations to be mass-produced. The fourth principle is, as in all medicine, first, do no harm. Hormones have powerful effects. When administered in excessive dosages, hormones increase risk in women. This includes overstimulation of breast glandular tissue, causing increased breast density, a known risk factor for breast cancer. Conversely, consistent underprescribing hormones leads to almost a guarantee of one of several of the complications of cognitive decline, osteoporosis, sarcopenia, atherosclerosis and coronary artery disease, heart attack and stroke, vaginal atrophy leading to the need for adult diapers, canes, walkers, wheelchairs, and the premature separation from home and family. A fifth principle is that proper treatment requires assessment, risk education, instruction, testing, and ongoing monitoring of each patient. Assessment. We implement a checklist. Key elements include a patient consultation agreement that details the entirety of the menopause treatment process. It specifies that the first year will include a minimum of 3 consultations to determine and test for optimal dosages, followed by annual evaluations. It describes in detail the initial and ongoing assessments and testings that we require, including traditional female examinations, blood and hormone testing, periodic mammography, bone density, as well as PRN transvaginal ultrasound and breast thermography. We require an online initial comprehensive female medical questionnaire, a short menopause treatment questionnaire preceding every follow-up consultation, as well as an annual visit questionnaire. Risk education. We are cognizant that every woman, whether she communicates about it or not, has risk concerns. We address those risks with her proactively based on a compilation of the most current medical research. Because this was brought up so often this morning, I recommend that you read the book Estrogen Matters by an oncologist, Dr. Avram Blooming. It's reference number 18. It's state-of-the-art. It was printed in September 2018. It's got 460-some references that will blow your mind about the safety of all hormones, including Prempro. The Women's Health Initiative was incorrect and was known to be incorrect in 2006. Prempro is safe. I never prescribed Prempro in my life, but it's a good thing to know. We do not proceed with treatment if a woman's concerns persist. Instructions. We provide each patient with one of 4 dose determination protocols, a symptom chart to identify clinical symptoms of insufficient and excessive hormone levels, online videos to provide patients a refresher for information communicated to them in an office visit on dose determination and hormone application. Testing. Testing is a critical part of proper hormonal dosing. I favor the 24-hour urine hormone test, for which I have correlated and defined target parameters for test results with the findings of the preponderance of the medical literature, and have defined optimal treatment goal ranges, not too much and not too little. Time considerations inspired me to condense into 5 minutes a subject I could elaborate upon for days. I humbly offer and request to be an ongoing resource for this committee in any way that you may desire. And in closing, I'd like to say that I've heard many things this morning that I'm not in agreement with. And I would like to address those in this question and answer period, should you so desire. Thank you very much for your time and this wonderful invitation from the National Academy of Sciences.